Good morning, everyone, and a very warm welcome to all the participants to this training on pediatric COVID-19 in children. And this training program has been organized by the DGME, DGHS, Department of Pediatrics, KGMU, Lucknow, along with other collaborating colleges. And these colleges are RML Hospital, Lucknow, SGPGI, Lucknow, IMS PHU, Varanasi, and Super Specialty Hospital, Noida, and SRMS, Bareilly. So faculty from all these medical colleges were involved in developing modules for this training program. And as we have seen that a small percentage of children were involved by COVID-19 infection in last peak, second wave of COVID-19. So we should be all aware about the proper management of pediatric cases. So if third wave happens, though nobody wants that third wave should happen, so then we should be able to manage children properly. So during this 4-day training program, we will discuss all aspects of management of pediatric COVID-19. And the first day is mainly focused on the management of mild moderate cases and the overview of COVID-19 in children. The second day is mainly focused on how to give oxygen therapy to these children and to do non-invasive ventilation. Day 3 is mainly focused on the mechanical ventilation, how to do mechanical ventilation in these children. And on day 4, we will further discuss some other topics. So hope we will be all, this training program will be helpful to all of you in managing children of COVID-19 infection. So we will shortly start, and before starting this session, there is a pre-test, and at the end of the training program, there will be a post-test. Okay? So giving pre-test and post-test is mandatory. And you have to attend all the sessions. You have to give pre-test and post-test. Then only you will get your certificate of participation. So don't forget to give your pre-test and post-test. And today, Dr. Raj Kishore from BRD Medical College, he is Associate Professor at BRD Medical College, Gorakhpur, will be the moderator of day 1 activity. So, welcome Dr. Raj Kishore. And over to you, Dr. Raj Kishore. And before we start,
good morning, everyone.
Good morning, Dr. Raj Kishore. Welcome.
Thanks a lot.
So before we start, I request Neeraj to brief something about the pre-test, about the link, and pre-test will start at 12:10, and you will be given 20 minutes to complete the pre-test. So all the best.
Yeah. Please start. Please give the option to share the screen.
Neeraj ji, pre-test link is already been sent to all of the participants. WhatsApp number. Neeraj ji.
Yes, sir.
Yeah.
All of you have received this message on your email, also on your WhatsApp. In this, you have 3 links basically. First is your link to join the training via Zoom app. The second link is If you have any issue in joining through the Zoom because of any reasons, maybe due to internet connectivity, you can also join using YouTube link where this webinar is live, and you can follow there. The third one is basically the third link which is shared is of pre-test, which is currently disabled, and it's also mentioned, the time is also mentioned in the message that it will be activated on 12:15, but today we have rescheduled it to 12:10. So we'll start this link on 12:10 and we'll close at 12:30. It is of the post pre-test will be of 20 minutes. So you have to click on this link. This link will redirect you to an browser where the pre-test will be open, and your name, mobile number, email ID, and also your participant ID will be pre-filled. If any of these indicate any of these values is not filled, request you to please again go to your WhatsApp and you have to click on this link again, so that your name, mobile number, email ID, and participant ID should be pre-filled. And this pre-test contains of 15 questions. You have to give answers, and at last you have to click on the submit button, and you can see a screen showing that your response has been recorded. Okay, we'll be starting pre-test from 12:10, and if you have any issue, you can just message on the number from which you have received this WhatsApp, so that we are here to assist if there is any issue in giving pre-test. Thank you.
Now,
Over to Raj sir.
12:08. After 2 minutes, the pre-test will start. Participation is in pre-test is must for continuing your training. Otherwise, from tomorrow, you will not get the link for the training. Participation in pre-test is must. I am repeating again. And participation in pre-test and post-test is must for getting the certificate of being trained. Otherwise, you all will not get the certificate. For continuation of the training, for all 4 days, participation of pre-test is must, and for getting certificates of the training from DGME office, participation of or submission of pre-test and post-test is must within time. It's now 12:09. After 1 minute, the pre-test link will be active. Click on the pre-test link. Your name, mobile number, email ID will be pre-filled there. You have to just click your answer and then just submit it by clicking on submit button. There are 15 questions and the time is allotted for the 15 questions to answer is about 20 minutes only. Means at 12:30 sharp, the link will be inactivated and it will not receive any response from anyone. The Google link or pre-test is a time-bound link. It will be active in between 12:10 to 12:30.
Activated,
Note
sir.
it.
Link is active.
Note it. And now it's 12:10 now. The link is active now, Neeraj. I think the link is active now. If any technical difficulty or glitch, kindly post in your chat box, or you can contact directly to Neeraj from Mamta. Dr. Kairunisa posted that link not yet sent. participants ID, everything you will get filled. When you click the proper link for pre-test, only you have to fill your answer, your name, your email ID, your mobile number will be already there. Link already sent to all participants on their WhatsApp number and their email ID. If you are not getting link from your WhatsApp number, you can search your email ID, email inbox. Dr. Karun Nisa Khan, posting link not received. Neeraj, please look into this.
Yes, sir.
Dr. Astha Pandey, where link will be visible? Dr. Astha, the link is in your email inbox or on our WhatsApp. Dr. Dinesh Kumar is posting his email ID. Dr. Spar Singh asking for participant ID. Participants ID आपको नहीं भरना डॉक्टर साहब, आप अगर करेक्ट लिंक क्लिक करोगे तो आपको वो सब भरा हुआ मिलेगा।
अगर किसी का पार्टिसिपेंट आईडी भरा हुआ नहीं आ रहा है तो प्लीज आप व्हाट्सएप पर जाकर प्री टेस्ट लिंक पर दोबारा क्लिक करें, आपकी सारी जानकारी भरी हुई आएगी। और स्टिल इशू हो रहा है तो आप उस व्हाट्सएप नंबर जिससे आपको लिंक आ रहा है आप उसमें मैसेज कर सकते हैं।
All participants, please note, it's now 12:15, means you have 15 minutes more to submit your pre-test response. Submission of pre-test response within the time frame is necessary for a successful participants and for continuing for next 3 days of the training. If we not receive the pre-test response, pre-test submission from anyone, he will not get the link for training from tomorrow. Dr. Ashish Kumar is typing in chat box, participants ID is not coming again. Neeraj ji, please look into the matter. Dr. Ashish Kumar is typing in chat box, participant ID is not coming again. Dr. Shobha Mukherjee typed, when we join the link, we come to this place. Please clear your question again, ma'am. Dr. Shobha Mukherjee, ma'am. क्या पूछना चाहती हैं आप? नहीं समझ पा रहे हैं.
डॉक्टर शोभा, जो मैसेज आपको व्हाट्सएप पर आया है उसमें 3 लिंक हैं, आपको तीसरी लिंक पे क्लिक करना है.
व्हाट्सएप पे जो आपको मैसेज मिला है उसमें 3 लिंक हैं, उसमें तीसरा लिंक मतलब कि अंतिम लिंक जो है आपके टेस्ट का लिंक है, उस पे जब आप क्लिक करेंगे तब आपको गूगल फॉर्म खुलेगा, उसमें आपका नाम, मोबाइल नंबर, ईमेल आईडी भराया होगा. सिर्फ आपको क्वेश्चंस के आंसर करने हैं और विद इन द टाइम फ्रेम यू हैव टू सबमिट इट फॉर सक्सेसफुल प्री टेस्ट. Dr. Sachin Kumar Gupta typed here, link will not open. Dr. Gaurav Kumar, link is not seeing. Link आपके WhatsApp पे है डॉक्टर साहब.
आप उस नंबर पर व्हाट्सएप करिए जिसपे आपको लिंक आया है.
हाँ, जिसपे से आपको लिंक आता है. कोई दिक्कत हो तो आप वहाँ व्हाट्सएप कीजिए, उसी नंबर पे व्हाट्सएप कीजिए कि आपको क्या दिक्कत हो रही है, या उस पे आप व्हाट्सएप कीजिए, रिक्वेस्ट अगेन, काइंडली सेंड मी द लिंक अगेन फॉर प्री टेस्ट. The Mamta people, Mr. Neeraj will send you the link again. It's 12:20 now. Only 10 minutes more to complete your pre-test. Please be quick. Nine minutes more. It's 12:21 now. Participation in pre-test and post-test is must for your certification. Participation in pre-test is must for continuation of as a participant in the training from tomorrow for next 3 days. If anyone is having difficulty to open the pre-test link, kindly send or kindly post your query to the same number. From here, you are getting the instruction about this training. They will help you. Three links have been already sent to all participants. The last link is the pre-test link. You have to click on the pre-test link. Already, you will get already filled here. Your name, your mobile number, your email ID. You have to only click on the answer of the questions. There are 15 questions, and the time allotted for 15 questions is 20 minutes. Is 12:23 now. You are having only 7 minutes to submit your pre-test. Five minutes more to submit your pre-test. There is no need to type submitted in the chat box. अगर आपने सबमिट कर दिया अपना आंसर तो हमें आंसर मिल जाएगा आपका. Just submit your pre-test. Four minutes more. Only 3 minutes more. After 3 minutes, the pre-test link will be inactivated automatically. I will not able to submit your pre-test. Now it's 2 minutes more. Please be quick and submit your answer. Dr. Ashish Kumar telling that no video or audio option coming on screen. Log out and log in again. Leave the meeting and log in again. It's not possible. If you log in correctly, the video and audio option will be there on your screen. Bottom of your screen, extreme left, there is audio option and just behind that, there is a video option. आपने सबमिट कर दिया, सबमिटेड हो गया. इट्स गूगल फॉर्म. ये गलत नहीं करेगा. आपने सबमिट किया है तो डोंट वरी अबाउट दैट कि इट्स सबमिटेड और नॉट. Only 1 minute left. Only 1 minute. Please submit your Google form. Otherwise, you will miss the opportunity. Only 1 minute. The last minute is going on. It's now 12:30. The link will not accept your response after 12:30. Now time is, Neeraj ji?
Yes, sir.
Now it's 12:30, 31.
31. Yes, sir. We
Time
can
is over
start
now?
training now. Yes, sir.
Your link?
It's deactivated, sir. We can
Activated
start
or not?
training. Yes, sir.
So now you can start the session.
Yes, sir.
Yeah. So I think all participants submitted their response of pre-test. So now we are starting the Pediatric COVID-19 Management Online Training of Medical Education Department of Uttar Pradesh. Thanks a lot for taking this great initiative and most needed initiative to train all the doctors of medical education department. And behind this great initiative, I salute Dr. N.C. Prajapati sir, Dr. Saili Avasthi ma'am, Dr. Chandrakanta ma'am, and the Mamta people for taking this great initiative. For today's session, our learned observers are Dr. Ruchi Rai from SSPH PGTI Noida and Dr. Ankur Singh from IMS BHU Banarasi. The first topic of today's session is COVID-19 in pediatrics, clinical presentation and management. And you all will be enlightened about this topic by Dr. Sanjeev Verma from KGMU Lucknow. I welcome you, sir. Dr. Sanjeev Verma, sir. Over to you. Please share your presentation and start your training session. Dr. Sanjeev Verma, sir. Sanjeev Verma, sir, from KGMU Lucknow. He will.
Good afternoon, sir. Thank you, Rajkishore sir.
Good afternoon, sir. Your slides are visible and you are audible also.
Thank you, sir.
You can
Good
start
afternoon,
now so that we can complete our all sessions within time. Your slides are clearly visible. You are audible also.
Thank you, sir. Good afternoon, Anshit Prajapati sir, Shaili ma'am, Chandrakanta ma'am, and Rajkishore sir. And thanks and everyone who is listening to me. I'm thankful for giving me opportunity for this opportunity. I am presenting an overview of COVID-19 infection in children, and my slides are moving and visible. Are my slides visible and moving?
Yes, slides are visible.
Thank you.
डॉक्टर साहब स्लाइड्स आपकी विजिबल है बट थोड़ी आवाज धीमे आ रही है. आवाज आ रही है बहुत धीमे आ रही है. हमें लगता है आपको माइक के पास जाके बोलना होगा. डॉक्टर संजीव वर्मा जी.
Yes, sir.
Your slides are visible.
COVID-19
voice is also audible, but the voice intensity is very low.
This novel coronavirus emerged in Wuhan province of China and spread all over the world, across the world, just by its transmissibility. So these are figures of last year and current year figures across the world and this year. We have faced our first wave in the August to September months of last year, and now we have seen just before just in April and May months of this year. So these are the pyramids of the how our population is distributed, and we are seeing that we are having a majority of population who is young, and a large chunk of population is less than 20 years of age. So, but population which is affected, if we are coming to the population which is infected with COVID-19 infection, is less than 3%, around 3% in less than 10 years of age, and around 9% in less than 20 years of age. So if we see as a whole chunk, we are still less than 12% of pediatric patients infected with COVID-19 infection. And if we come to the mortality with COVID-19 infection, less than 3% of mortality occurred during in less than 20 years of age. And if we come to less than 10 years of age, it is again less than 1% of total COVID-19 infections. So why there is research in the COVID-19 infection? First of all, there is complete lowering of the guards, the things we are following for prevention of COVID-19 infection, social distancing, avoiding crowds, avoiding routines, not going outside, and taking extreme of measures for prevention of COVID-19. We thought we have defeated coronavirus after the first wave, so we lowered the guard, and we are facing this situation. There is complete state of unlock. Second thing is complete state of unlock. Complete state of unlock means we
डॉक्टर
resumed
संजीव
our
वर्मा जी,
yes
सॉरी
sir.
फॉर इंटरप्शन, आप प्लीज अपना ना वीडियो अपना ऑफ कर दीजिए ताकि आपकी साउंड क्वालिटी और अच्छी हो जाए. बहुत सारे पार्टिसिपेंट्स लिख रहे हैं चैट बॉक्स में कि साउंड क्वालिटी, साउंड वॉल्यूम बेसिकली कम है. साउंड क्वालिटी इज वेरी गुड,
Okay.
बट सॉल्व.
Thank you, sir.
हाँ, यस
I've-
यस यस.
So there is complete state of unlock. So we have resumed our routine works. We are going to offices. We are doing routine marketing, and we are exposing them ourselves. There are certain events in form of mass gatherings, in form of elections, and certain other gatherings, and we have also started gatherings in form of like uh, um, social functions also. And despite in these gatherings, there is again lack of adherence to this social physical distancing and mask use. And what is more threat is mutant strain. So mutant strain are due to emergence of certain changes in the viruses, especially in the spike protein regions, through insertions and through deletions, and that have led to a lot of mutations in the COVID-19 infection. And this COVID-19 infection, COVID-19 virus, mutant COVID-19 virus have led to increased transmissibility, increased infectivity, and reinfection. And there is escape mechanism from COVID-19, not only vaccination, and there is certainly few mutants are resistant to treatment also that we are offering. So again, we have to go back to the preventive measures for COVID-19 infection prevention. What are these? These are doing physical distancing, proper use of mask covering both nose and chin, not touching it, regular cleaning of hands. If they are visibly dirty, then we have to do hand wash, and if they are clean but still we have to do routinely use of sanitizers. Cover your face during coughing and sneezing. Proper waste disposal. Don't spit here and there, and don't touch unnecessary, even your mask and unnecessary things. Avoid unnecessary outings. Avoid unnecessary crowds, and vaccinate yourself. These are the key measures for prevention of COVID-19 infection. Then there is a question whether children are more prone in this search. There is definitely absolute numbers in all age groups have been gone up, definitely, but children proportion are children are proportionate to this increase in number. So children's number have increased, but they are in proportion to these increased number of cases. And this proportion has been consistently less than 12%, and mortality is even less. But definitely, but definitely most of the adult population is being vaccinated, and still children are not vaccinated. And there is again emergence of new very severe form of illness, that is multi-system inflammatory syndrome. So these are cause for COVID-19 infection susceptibility for children, but there are other things also, that secondary infection rate is quite low in children, and there is very much less chances of severe COVID-19 infections. So these favors that COVID-19 infection third wave might not be that much severe, but still we have to be prepared, and for that we are doing this. So how COVID-19 infection is affecting children? It may affect affecting the children by causing acute respiratory tract infection or lower respiratory tract infection. Other organ involvement, it may cause multi-system inflammatory syndrome or atypical presentation. But it is also affecting children by indirect measures, by downscaling and closure of regular child activities. Their vaccination is being affected, their learning and mental health is being affected, as they are not able to go for schools, they are not able to play outside, and they are also being affected in their environment, as their parents are at home, they are not going out for work, and they are not earning, so they are affected in those forms. And if they are their parents are not earning, definitely those who are belonging to lower socioeconomic status, they are also being affected by their nutrition. So what are the modes of transmission? So this is a respiratory virus, and it is mostly transmitted by contact transmission, droplet transmission, and airborne transmission. But initially there was excessive emphasis on contact and droplet transmission, but this is also came in recent studies that airborne transmission may occur, especially in closed spaces. But if we are in open spaces, the airborne transmission chances are big. How to diagnose? For diagnosis, there are multiple tests available. The first and foremost is reverse transcription polymerase chain reaction. The other forms are cartilage-based nuclear amplification test, expert or TrueNAT. CRISPR, that is clustered regularly interspaced short palindromic repeats, or loop-mediated isothermal amplification. These are new ones. Antigen detection test is point of care test, and antibody detection test is may not tell that acute infection is there, but it may tell that infection have occurred. So it is important in diagnosis of multi-system inflammatory syndrome. So what are the specimen we have to collect? Basically, these are nasopharyngeal or nasopharyngeal swabs, bronchoalveolar lavage. Sometimes sputum and salivary can be used, but they are avoided. Preferably nasopharyngeal and bronchoalveolar lavage are the preferred respiratory specimen. So still we are mainly focusing on RT-PCR, CBNAT, and TrueNAT. Antigen detection test from nasopharyngeal swab gives a very high specificity but low sensitivity. So even if antigen test is came to be negative, so we can go for a repeat RT-PCR or CBNAT test for diagnostic purposes if we are strongly suspecting that this child is infected with COVID-19 infection. Incubation period. Incubation period is the period from the entry of the virus or any organism to the disease manifestation. Median incubation period in COVID-19 infection is 3 to 5 days, but it may extend from 2 days to 10 days. Is the COVID-19 child can transmit infection before onset of symptoms? Yes, COVID-19 infection can be transmitted 2 days before onset of symptoms. So even those who are exposed, they may transmit infection even if they have not infected. So what are the spectrum of COVID-19 infection? So there could be pre-symptomatic, the child, a time period between exposure to the virus and development of symptoms. So still the child has not manifested, but he can infect others. Asymptomatic, if the test is positive and the child is not having any clinical symptoms or signs, then he will be called asymptomatic COVID-19 infection. These children are mostly identified during contact tracing. Classical manifestation, usually with fever, upper respiratory tract infection like symptoms, lower respiratory tract like infection like symptoms, or there could be GI manifestation, or there could be atypical symptoms. So this, what are the atypical symptoms? Atypical symptoms could be GI, could be cutaneous, or could be multi-system inflammatory syndrome. So the GI symptoms occurs, gastrointestinal symptoms occurs in less than 5 to 10% of the children with or without respiratory symptoms. These are diarrhea, vomiting, abdominal pain. Other cutaneous manifestation in less than 3% of the cases includes maculopapular, urticarial, and vesicular eruptions or transient levator-reticularis. What is missed? These all the things will be detailed, covered in further lecture, and missed is further covered in coming slides. So, how to assess the severity of the child? We can classify COVID-19 infected child into mild illness, moderate illness, or severe illness. So those with mild illness, they have just URTI-like symptoms, sore throat, rhinorrhea, or cough, but there is no respiratory distress and there is no even fast breathing. So even if a child with no other ill manifestation is having respiratory distress or increased work of breathing, that child will be classified into moderate illness. So what is moderate illness? More than 60 rate in less than 2 months of age, more than 50 rate in less than 1 year of age, more than 40 rate respiratory rate in 1 to 5 year of age, and more than 30 for 5 years of age. Without any evidence of, with or without any evidence of increased work of breathing. What is increased work of breathing? This is will also be covered in subsequent lectures. What is severe illness? Severe illness could be severe pneumonia, could be acute respiratory distress syndrome, or without respiratory distress, this could be septic shock or multi-organ dysfunction syndrome. There might be cyanosis, there might be hypoxia, there might be increased respiratory effort with letharginess, somnolence, and seizures. So coming back to mild illness, this mild illness mostly presents like influenza-like illness, but there is absence of any respiratory distress or absence of any hypoxia. So these are respiratory rate limits which have to be absent while labeling a child with mild disease. Few children may have some other GI upset like nausea, vomiting, abdominal pain, but they will still considered in mild disease only. On physical examination, general physical examination, there might be condition of the pharynx, but there should be definitely no respiratory abnormalities. So these children can be managed at home provided they should be fulfilling these criteria. Their respiratory rate should be below their age specific cutoffs. If the answer is yes, then they can be home isolated. They should be maintaining SpO2 more than 94%. There should be absence of any high risk features like any cardiovascular comorbidity, any diabetes, immunocompromised state, any chronic lung disease, chronic kidney disease, chronic liver disease, any cerebrovascular disease, or obesity. Even obesity, if more than 2 standard deviation, they have to be offered for hospital management. If these are absent, then they can be home quarantine. But they should also be fulfilling some other criteria that the patient has requisite facility for home isolation at his or her residence. Caregiver is available to provide care on a 24/7 basis, and they should be following using a country-specific app for tracking of COVID-19 infection. In India, this is Arogya Setu app. And the parents or caregiver has agreed to monitor health of the child and regularly inform to his health surveillance officer or a doctor. And they are consented for home isolation. If these all answers are yes, then this child may be home isolated. But even in these conditions, if the child, there might be need for hospital admission, if the house is very small, overcrowding at home, another high-risk patient is staying at that same house, or regular monitoring is not possible due to any reason, it may be far from the home or whatever the reason, or there could be comorbidity like immunosuppression or chronic disease. So all these children should be admitted if these flaws are. So what is the duration of home isolation? In adults, duration of isolation is 10 days. But as children, even if symptom-free, can shed the viruses in for 28 days. Though there is no consensus, but general agreement is that 2 weeks after COVID report, there is a safe period for home isolation. Coming to moderate COVID-19 disease, any child with having fast breathing, that is more than 60 per minute if less than 2 months of age, more than 50 per minute if age is 2 to 12 months, more than 40 respiratory rate if age is 1 to 5 years, more than 30 respiratory rate if age is more than 5 years. And no signs of severe pneumonia. What is severe pneumonia? I will tell at a slide. Oxygen saturation may be less than 94%, but it should not be less than 90%. So these all children with moderate disease has to be hospitalized COVID-19 dedicated pediatric wards, and they have to give in oxygen therapy and other supportive measures. Mostly paracetamol and oxygen is required, and regular monitoring of their vitals. What is severe illness? Severe illness is severe pneumonia, that is COVID infection with increased respiratory rate and hypoxia less than 90%, or acute respiratory distress syndrome, or other organ dysfunction in form of septic shock, multi-organ dysfunction, or pneumonia with cyanosis, hypoxia, increased respiratory effort with lethargy, somnolence, increased sleepiness, or seizures. So this is severe illness. So these all have to be admitted in COVID dedicated center in pediatric ICUs. Further, severe illness can be classified into can be grouped in ARDS or shock-like picture. ARDS with a predominantly pneumonia-like picture, where acute respiratory distress syndrome, mild ARDS can be managed with high flow nasal oxygenation or non-invasive ventilation, or severe ARDS might be needing mechanical ventilation, fluid, and sedation. But other picture could be of not maintaining perfusion requirements, that is shock. It could be septic shock or a myocardial dysfunction related shocks. So all severe COVID-19 infection related child should be admitted, preferably in COVID-19 dedicated pediatric ICUs. They should be sent for required investigation after confirming COVID-19. These have to be evaluated for thrombosis, organ failures. They have to be given steroids with or without remdesivir. These all severe COVID-19 infection treatment and guidelines will be discussed in further lectures. They have to be given oxygen therapy. They do not have to given liberal fluid therapy. They have to given restricted fluid therapy and organ replacement therapies like renal replacement therapy if required. There is one more entity that has interestingly coming more and more in this COVID-19 scenario, that is multi-system inflammatory syndrome. And what is the definition for MISC? Any child who is less than 19 years of age with fever for more than 3 days, and any two of these 5 organ involvement, whether it is rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation, not maintaining blood pressures or perfusion in form of hypotension or shock, features of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities detected on echo, or evidence of dysfunction of cardiac abnormalities on investigation in form of elevated troponin or proBNP, evidence of coagulopathy defect like increased PT, APTT, or elevated D-dimer. Or there could be acute GI upset in form of diarrhea, vomiting, or abdominal pain. So any two of them with a fever of more than 3 years of age in a less than 19-year-old child with high elevated markers of inflammation, that is high ESR, CRP, or procalcitonin, along with no other explanation or microbial cause for this episode. There is absence of bacterial sepsis, staphylococcal or streptococcal shock syndrome, and there is either COVID-19 RT-PCR should be positive, antigen test should be positive, or there could be serology positive. So if the child is having fever of more than 3 days with 2 organ involvement, high inflammatory markers, with absence of any other organism explaining these, and there is evidence of COVID-19 infection, whether it is active or in form of serology positive. So this child will have to be treated as MISC. Treatment and further guidelines will be discussed in further lectures. So this is again a serious condition and has to be admitted in COVID-19 dedicated PICUs. So what we have discussed till now, that COVID-19 infection prevention has to be taken care with physical distancing, use of mask, cleaning of hand, regularly cleaning of hands with either hand wash or sanitizers, and taking all precautions for COVID-19 infections. We have identified manifestations of COVID-19 infections. We have identified incubation period of COVID-19. Even those who are asymptomatic or pre-symptomatic, they can transmit the disease. So they have also been means identified, and they have to be isolated. So I have told what are the prerequisites for home isolation. I have told what is moderate disease and what is severe disease and MISC, and where they have to be managed. Now, few of the recommendations that have to be that came up in last few days or months. So that has to be followed. There is strong recommendation of systemic steroids in patients with only severe and critical COVID-19 infection, not in all COVID-19 patients. There is a conditional recommendation against systemic corticosteroid in all children with non-severe COVID infection. There is conditional recommendation that remdesivir should not be given in all hospitalized patients with COVID-19 infection. So they have to be restricted and selected for severe and critical COVID-19 infection. There is strong recommendation against hydroxychloroquine in patients with COVID-19 infection of any severity, not to use ivermectin in children with COVID-19 infection, except for clinical trial, and not to use these antivirals like lopinavir and ritonavir in patients with COVID-19 infections. So this is my presentation, and thanks to all for listening to me. These are all contributors and organizers for this presentation, and they all have viewed and analyzed the. This is from my side. Over to you, Dr. Raj. Any questions you can ask me in the chat box. I will answer.
Dr. Ashok Yadav is asking for any conditional recommendation for remdesivir. Please elaborate. Dr. Sanjeev Verma ji.
It's for COVID-19
asking for
infection.
Conditional recommendation for remdesivir.
Sir, remdesivir use is covered in later lectures, so I will not be discussing it over here. It's just an overview of COVID-19 infection in children.
Dr. Monica Rai is asking for ivermectin.
Ivermectin should not
will be covered in following sessions. From tomorrow onwards, there is a very detailed session on treatment. This session was just for introduction to COVID-19 in pediatrics.
Discussed in later
now
on a lecture.
Thanks a lot for delivering such a nice deliberation by Dr. Sanjeev Verma ji. Thanks a lot, sir. Now we are going to start the second topic, recognizing a sick child, normal vitals and trace. And this topic will be delivered by myself. So I am sharing my window. Please stop sharing your window, Dr. Sanjeev Verma ji. So can I share my window?
I have stopped sharing.
My slides are visible now?
Yes, sir.
I think it's now full screen. Yeah. So now I'm starting my presentation. I am Dr. Rajkishore Singh, Associate Professor from BRD Medical College, Gorakhpur. I will tell about recognizing a sick child, normal vitals and tracing. Basically, it's very vital in the management of COVID-19 as whole, and especially for the third wave, for which we are preparing and we are conducting this wonderful training. The learning goals are vital signs, pulse oximetry as a fifth vital sign, how to recognize a sick child, what are the red flag signs, and how we can trace a pediatric patients with a COVID. We all know what are the vital signs. Their temperature, heart rate, respiratory rate, and blood pressure. And the assessment of these all is very critical for recognizing how sick your child is and how we can trace where we have to place that child. The first, we'll revise some beautiful facts about temperature. The normal body temperature ranges between 97.8 to 102 degree Fahrenheit. The fever is defined as temperature more than 100.4 degree Fahrenheit. And hyperpyrexia is temperature more than 104 degree Fahrenheit. I am repeating again. Normal body temperature is 97.8 to 102 degree Fahrenheit. Fever more than 100.4 degree Fahrenheit. And hyperpyrexia is more than 104 degree Fahrenheit. Any abnormal rise in body temperature is considered a symptoms of underlying condition. Highest temperature is reached in evening and is slightly lower in the morning. So these are the facts about the vital sign temperature. Now heart rate. Heart rate varies as per age. In neonates, normally it ranges between 100 to 205, but in adolescence, it ranges between 60 to 100. So there is a wide range, and there is a wide range also for sleeping heart rate. But it's not very difficult. We have to memorize only few things. First one is bradycardia is heart rate below 60 beats per minute for all age groups. If anyone is having heart rate less than 60 beats per minute, means he is bradycardiac. Tachycardia in infant is considered when the heart rate is more than 220. Tachycardia in a child when the heart rate is more than 180. And tachycardia in an adolescent is when the heart rate is more than 100. If we memorize these 3-4 data, less than 60 bradycardia, more than 220 is tachycardia in infant, more than 180 is tachycardia in child, and more than 100 is tachycardia in adolescents. So it's sufficient, especially for our non-pediatrician colleagues present here in the training. Tachycardia is very common in children in acute setting resulting from fever. It may be due to dehydration, or it may be due to a life-threatening condition such as shock. It's not always due to infection only. Now the respiratory rate. Like heart rate, respiratory rate also varies as per age in pediatrics population. It's very easy for pediatrician colleagues, and they are really very trained and very excellent for the respiratory rate ranges for different age groups. But it's also very simple for our non-pediatrician colleagues, which is very much needed for the management of third wave. They will assist also. There is so many non-pediatrician friends, non-pediatricians colleagues in this training. So the fast breathing, consider fast breathing in a pediatrics age when it is more than 60, if the age is less than 2 months. More than 50 if the age is in between 2 to 12 months. More than 40 if it is the age is in between 1 to 5 years, and more than 30 if the age is more than 5 years. So as unlike in adults where we are taking fast breathing when the breathing rate, respiratory rate is more than 24, here in a child is more than 5 years, if he is breathing at a rate of more than 30, he is having fast breathing. For age group 1 to 5 years, more than 40. For the age group 2 to 12 months, more than 50. And for age group less than 2 months, the 60 is the limit. The blood pressure is an indirect surrogate marker of cardiac output, and it also varies as per age. Hypotension is defined as the blood pressure below the 5th centile for age, and fall of systolic blood pressure more than 10 mm is really worrisome and usually a sign of shock. But unlike in adults, hypotension is not synonymous with shock in infants or in pediatric age group. Hypotension in pediatric shock patient is a very late manifestation, usually late manifestations, and is an ominous clinical finding. Compensated shock will have normal BP in pediatric age population with poor perfusion. Shocks should be recognized in compensated stage. There is a very beautiful lecture during the following days of the training about shock and how to recognize shock in a pediatrics population. Here we are only revising the cutoff, systolic blood pressure cutoff as per age for recognizing hypotension. In a term neonate, if systolic BP is less than 60 millimeter of mercury, the neonate is hypotensive. In an infant up to 1 year of age, if the systolic blood pressure is less than 70, he is hypotensive. In a children between 1 to 10 year of age, the systolic BP cutoff will be calculated by the formula 70 plus 2 into age in year. Suppose a child is of 9 years of age, presenting to you, so his systolic BP cutoff for considering hypotension will be 70 plus 9 into 2, means 70 plus 18, means 88 will be the systolic BP cutoff for consideration of hypotension in a 9-year child. For 10 years or more, the hypotension, systolic BP hypotension cutoff is 90 mm of mercury. So it's also very simple, and it also varies as per age as all other vital parameters like heart rate and respiratory rate. Now, in a COVID era, especially in COVID era, pulse oximetry is also taken as a 5th vital sign and very much necessary to categorize your patients, COVID patients, and for the triaging of your patients. The pulse oximetry measures oxygen hemoglobin saturation as SpO2, assessed in children with respiratory or cardiac illness and underlying abnormalities of oxygen. Healthy children had SpO2 more than 95. Underlying cause should be evaluated in children with SpO2 less than 93 to 95. But there are some caveats about pulse oximetry. It's a poor indicator of blood oxygen content and tissue oxygen delivery. Does not indicate CO2 status and efficacy of ventilation in a patient, either pediatrics age group of a pediatrics age group or adult age group. It's a poor indicator of hyperoxia, and its use is limited in a poorly perfused child, a child with a very poor perfusion, where the capillary field timing is very much delayed. The pulse oximetry findings are misleading. So we have to rely on ABG. If there is any doubt, you have to go for ABG. There is a very beautiful, wonderful lecture on ABG during the following days of the training, either second, third, or fourth day. Recognizing a sick child. Now, after knowing the cutoffs for the various vital parameters like temperature, heart rate, respiratory rate, and SpO2. Now, we can very easily, even our non-pediatrician colleagues present here in the training can very easily recognize a sick child. And recognizing a sick child is based on a very, very well-validated, structured approach. And the steps of that structured approach are initial assessment, primary assessment, secondary assessment, and diagnostic test. We learn one by one in breathing and color. Appearance may be lethargic or active. Breathing may be fast. Respiratory rate as per the age criteria, more than 60, more than 50, more than 40, or more than 30. And the color may be pale, cyanosed, mottled, ashen gray, or anything. Initially, we can look the patient, and for this, the proper exposure of the patient is a must under a well-lighted area. In primary assessment, we'll do A, B, C, D, E. We look for the airway. Is it open and maintainable or not? We look for the breathing rate, work of breathing, and SpO2. We look for circulation by counting heart rate, by looking capillary refill timing, by looking or by measuring blood pressure, peripheral, looking for peripheral pulses, color, and temperature. We can assess the circulation of a child or any patient, and we look for the extent of disability as per ABPU scale or GCS scale. The doctors will rely on GCS scale. The ABPP scale is for paramedicals, where a children is assessed as A for alert, B for verbal response, P for response to a painful stimulus, and U for unconscious. Your paramedical staff will tell you the patient is landed here in a state of U, sir. U means he is unconscious. In a state of A means alert. In a state of B means he is not alert, but he is responding to the verbal stimuli. And P, he is responding to a painful stimuli, but not the verbal stimuli, is not alert. So the ABPU scale is used in triage area by your paramedicals. You have to use GCS scale and memorize this. And these are well explained in the during the next lectures in detail. Exposure of these all, for these all, exposure is must in a well lighted area. Your triage area should be well lighted, and everyone will be well trained to recognize the vital sign and their cutoffs. And it will be easier for your non-pediatrician people if you print a cutoffs for different vital signs as per age and paste it to your triage area. Exposure is also necessary for looking at skin rashes, redness, swelling of hand and feet, and any other relevant examination. In secondary assessment, we will take focused history about fever, running nose, loose stool, poor feeding, and positive contact history, if any. And we'll do focused examination through head to toe. Especially the vital signs are must for your triaging, for placing your patient at the appropriate level and at appropriate place for a better outcome. In secondary assessment, we will also go for diagnostic tests and collect samples for blood glucose, complete blood count, electrolytes, arterial blood gas analysis, liver function test, renal function test, coagulation test, markers of inflammatory mediators, and chest X-ray. Now, the last step is the step of evaluation. After doing these all, after knowing the vitals cutoffs as per age, after doing initial assessment, after doing primary and secondary assessment, now we all are able, even our pediatrician colleagues are able to evaluate a child. He is lethargic, he is having fast rate, he is cyanosed, mottled, Essengrain, his respiratory, what is his respiratory rate, what is his SpO2, less than 94 or not, what is his work of breathing. The work of breathing is assessed by nasal flare, chest withdrawing and grunting. It's very important in pediatrics age population. Even if a patient, if your pediatric population, pediatrics age group patient is having normal respiratory rate as per his age cutoff, but work of breathing is increased. It's indicate a bad outcome, and it's indicate that the child is having a severe disease. The work of assessment of work of breathing by nasal flaring, chest withdrawing, and grunting is important. We have to recognize tachycardia, hypotension, cold extremities, urine output, lethargic or unconscious and skin rashes, fever, sore throat, rhinorrhea, loose stool, stomach ache, redness and swelling of tongue, redness and swelling of hand and feet, oral mucosa sunken or sunken eyes, and skin pinch. Skin pinch may be very slow or immediate. If skin pinch is taking more than 2 second duration, it's very slow. Less than 2 seconds, it's slow. And if it is immediately coming to normal, means it's immediate and it's normal. After evaluation, after noting down the vitals, all 5 vitals as per each cutoffs, we had to look for the red flags. Red flags in a children, in a pediatric population, is fever more than 3 days, SpO2 less than 94, cyanosis, presence of cyanosis, respiratory rates more than cutoff for the age, more than 60, more than 50, more than 30, and more, more than 60, 50, 40, and 30, and presence of chest withdrawing or increased work of breathing, any features like nasal flare and grunting, and presence of feature of MIS. MIS is a very deadly complication, and there is a very good separate lecture on MIS in the coming days of this training session. We have to also look for the general danger sign. These are your patient is not able to breastfeed or drink, is vomiting everything, there is convulsion, there is lethargy or unconsciousness. So these all are general danger signs, irrespective of age, in between 2 months to 5 years of age. Now, after learning all these, we can triage our patient based on his temperature, SpO2, presence of contact with recent or current confirmed COVID-19 cases, presence of symptoms, and uh, um, by collecting the samples, relevant samples, blood samples, etc., for screening and triaging. In triaging, we have to categorize our patient in mild, moderate, and severe category. A severe category patient is having fast respiratory rate, increased work of breathing, SpO2 less than 90. So there are three criteria, most important criteria. Basically, three criteria. Respiratory rate is fast as per age-based cutoff. Increased work of breathing means presence of flaring of ala nasal, working accessory muscles of breathing and grunting, and SpO2 is less than 90. Fever is present everywhere in mild, moderate, and severe cases. Cyanosis, circulatory insufficiency means hypotension, and general danger signs may be present or may not be present. So if any patient is having SpO2 less than 90, his work of breathing is increased, and his respiratory rate is fast, and is having fever, should be categorized as severe. If any patient is having fast respiratory rate and his SpO2 is between 90 to 94, but work of breathing is not increased, then he should be categorized as moderate case. And if your patient is having SpO2 more than 95, normal respiratory rate, work of breathing is not increased, circulatory insufficiency, danger signs, cyanosis, nothing is present, he should be categorized as a mild case. So for even our non-pediatrician colleagues, the categorization of patients based on the symptomatology, based on your observation, and based on your recording of vitals, all 5 vitals, you can easily categorize the patients in mild, moderate, and severe category. You have to consider comorbid conditions also, like presence of T1DM, type 1 diabetes mellitus. Also in obese children, T2DM. Children can have T2DM, can present with T2DM. Presence of cardiac diseases, congenital heart diseases, chronic lung diseases, chronic kidney diseases, or patient on dialysis, chronic liver diseases, neurological diseases, any psychiatric illness, obesity, severe malnutrition, steroid therapy, chemotherapy, or cancers. These all comorbid conditions के लिए आपको पूछना है, उसको नोट डाउन करना है. And after recording vitals, after during assessment, after categorizing your patients, after noting down the red flag signs and general danger signs and comorbidities, now we all are able to place our patient appropriately as per his severity for a better outcome. And this is the last step of triaging. Asymptomatic, mild, absence of comorbid condition, place in a quarantine facility, or you can allow for home isolation. For a patient with a moderate illness, place that patient in COVID HDU. A patient with severe illness, place that patient in a COVID PICU. And if your patient is having MIS, place in PICU and or HDU. So basically, you have to categorize mild, moderate, severe. Mild, home isolation; moderate, HDU; and severe, PICU. Severe with comorbidity, PICU. Or patients with moderate illness and having red flag signs, PICU. So in conclusion, assessment of vital sign is critical. Age appropriate cutoffs should be known and mastered. Our pediatrician colleagues are really very rigorously trained in this, and they are excellent for recognizing cutoffs for different age groups for different vitals. But it's not very difficult for our non-pediatrician colleagues. Recognizing a sick child can be done by a structured approach. Evaluation comprises of initial assessment, primary assessment, and secondary assessment. COVID-19 patients can be classified into mild, moderate, severe cases based on the evaluation. Red flag signs, general danger signs, and comorbid condition must also be assessed for proper placing of a sick child. A skill to be enhanced, especially for non-pediatrician colleagues. These skills, our pediatrician colleagues are excellent in these skills, but our non-pediatrician colleagues should learn how to count respiratory rate, how to record BP in a pediatric population, how to record axillary temperature, and how to use pulse oximeter properly, correctly in any patients. So for this, you can go you can Google it, and there are very good videos, and you can learn this very needed skill for management of COVID patients. These are our references, and my sincere thanks to all contributors from the different great institutions like SGPGI, KGMU, RML, Lucknow, IMS, BHU, AIMS, Raebareli, SPH, PGTI, Noida, for contributing these slides. Thanks a lot for participating and listening me. Now I am handovering the session to our next speaker, I am trying to basically, yes, yeah. I'm stopping sharing my slides. I invite, 1 minute please, Dr. Naveen Pandey from Santosh Medical College, Ghaziabad, for delivering his lecture on management of mild COVID, monitoring during home isolation. Welcome, Dr. Naveen Pandey. Please share your slides. Yes, he shared his slides. Well,
So, am I audible? And my slides
yeah,
are visible.
yeah, you are audible.
Yes. Okay. Thank you, sir. Good afternoon,
Slides are
respected
visible.
faculty members. Okay.
Now you can
Good
start.
afternoon, respected.
Dr. Naveen
Yes,
ji,
sir.
you can start. Yeah.
Yes. Sir. Good afternoon, respected faculty members and my dear colleagues. So, in this session of this session, actually, we discuss about the management of mild COVID-19 in children and monitoring during home isolation. So the learning goals for this session will be clinical features of mild COVID infections in children, home isolation and its feasibility, symptomatic treatment, treatment of children with comorbidities, where will the red flag signs, do's and don'ts to treat or to manage mild cases of COVID-19, and how we can monitor the child in home. So in mild COVID cases, the basically clinical features will be fever with sore throat, rhinorrhea, cough, diarrhea, vomiting, but there will be no fast breathing as per the criteria given by the sir in previous lecture as age-based criteria. So this is the pictorial presentation of the clinical features, which showing the fever with more than 38 degrees Celsius with sore throat and rhinorrhea and cough, then the clinical features of diarrhea and vomiting. So in management of mild cases, so these child can be managed at home with home isolation, and these child will be given only symptomatic treatment. So what are the points for home isolation? The points will be there is requisite facility for isolation at child resident and also for quarantine the family contacts also. Parents or other care taker who can monitor and take care of child, and if available, Arogya Setu app should be downloaded and their mobile phone. The parents and caregiver has agreed to monitor health of the child and regularly inform her health status to the surveillance officer or doctor. They should fulfill an undertaking or consent form before going to self-isolation and shall follow the home isolation quarantine guidelines. So the symptomatic treatments of mild COVID cases are treatment of mild illness in home isolation by paracetamol for fever, and the dose will be 10 to 15 mg per kg per dose, and that can be repeated for every 4 to 6 hours. For cough, we can give the throat soothing agents like warm water, saline gargles in older children more than 5 years and adolescents. Fluids and feeds to ensure oral fluids to maintain hydration and nutritious diet. As there is a cases, there are some comorbidity cases also with mild disease. They also can be managed at the home. These are some congenital heart disease or some chronic disease or chronic lung diseases or any other chronic organ dysfunction. And if there is obesity with BMI more than 2 standard deviation, then they also can be managed at home isolation, but we should know when they should be admitted to the facilities. If there is any deterioration from the baseline of their monitoring, then they should be admitted to the facilities, uh, level 1 or STU or PICU. Then if there is a lack of proper arrangement to manage at home, then also they can access to the health facility. So for home monitoring, what are the do what we should do? Monitor at home, explain the patient's caregiver to maintain a proper monitoring chart. Counting of respiratory rate 2 to 3 times a day. When child is not crying and he or she should be calm. Look for chest indwelling, nasal flaring. Bluish discoloration of skin, lips, nail bed. Is there any cold extremities? If the child is not taking orally proper and the child is lethargic, then also if there is a decreased urine output, oxygen saturation monitoring should be done by handheld pulse oximeter, and there should be regular communication to doctor or healthcare worker. Parents and caregivers should be explained whom to contact in case of emergency. Regarding maintaining monitoring chart, the caregiver should count respiratory rate 2 to 3 times a day and look for these danger signs like chest indwelling, nasal flaring, cold extremities, activity level, feeding, and hydration status. And for measurement, they can measure two parameters, temperature and SpO2, temperature by thermometer and SpO2 by pulse oximeter. So this is a format for monitoring baby and home isolation. So this is the format of monitoring chart. So this should be on day wise, and there will be 2 to 3 times monitoring of each and every parameter like respiratory rate, SpO2, temperature, and caregiver should look for chest retractions, nasal flare, GI symptoms, or hydration or urine output. And if there is another other things to mention, then he or she should mention on others. What we don't have to do in managing mild cases, no investigations required to manage the mild cases, and no chest x-ray, no CT, no antibiotics, no steroid, no role of hydroxychloroquine, favipiravir, ivermectin, lopinavir, ritonavir, remdesivir, imipenovir, and any immunomodulators. Tocilizumab, interferon B11, and convalescent plasma, they don't have any role for managing mild cases. What are the red flag signs? If there is a deterioration of the symptoms, if there is a persistent of fever for more than 3 days of more than 100.4 degree Fahrenheit, then if there is a fast breathing, if respiratory rate is more than 60 per minute for child of age group 0 to 2 months, and more than 50 per minute for infant of age group 2 to 12 months, and more than 40 per minute for the child age of 1 year to 5 years, and more than 30 per minute for child of age of more than 5 years. And if there is a SpO2 less than 94%. Persistent dizziness, letharginess, poor feeding, cold extremities, decreased urine output at least 6 times a day for infant. They should mention. And if there is any skin rashes, red eyes, pale, gray, bluish skin, lips, nail bed, then they should contact the healthcare facilities. So these are the references and bibliography for my session, and skill to be enhanced for management of mild cases, mild COVID-19 cases. So we should know how to assess temperature and how to take the temperature by thermometer, proper counting of respiratory rate, assessment of hydration status, and recognizing the blood flags. Thank you so much. Any questions? Hello.
Dr. Rajkishore, unmute. Unmute yourself.
Sir, please unmute yourself.
Sorry, maybe unmuted tha. So we can go for lunch as per agenda given, or we can proceed further for your lecture. Dr. G. Chaudhary ji. Dr. G. Chaudhary ji, can we proceed further? Are you ready? Because we are too early. It's too early, or we can take a break. As you advise, sir, we can take a break. Hello? Break lena? So we will collect. All participants are requested to rejoin after 20 minutes. Rejoin after 20 minutes. It's a lunch break for 20 minutes. And after the lunch break, it's about 1:50 now, and we will collect again at 2:10. Sharp at 2:10. We'll start our next lecture of this session sharp at 2:10 p.m. And there are two more lectures. One will be delivered by Dr. G.S. Chaudhary from GMC Jalon, and one will be from Dr. Neeta Radhakrishna from Noida. And both lectures are of very much importance in COVID management of moderate COVID in level 2, and interpreting chest X-ray. They are excellent lectures which we will take after lunch, and then we will conclude the today's session. We all will collect again at 2:10 p.m. today. किसको? उसके बैटरी को दिक्कत है बेटा, गाड़ी की बैटरी में दिक्कत नहीं खुल रही है। हाँ, नहीं खुल रही है, चेक कर लिया ना, बताया था मैंने। चौसिया जी आ रहे हैं, उसको निकलवा लो।
अभी वो डेट ऑफ बर्थ चाहिए था इसलिए नहीं हो पाया, कर लेंगे हम।
ओके ठीक है। एंड इसके अलावा कोई इशू मैम?
यही दो क्वेश्चन।
ठीक है, देखिए मैंने उससे बात की थी एक्चुअली।
Welcome back, you all. Now it's 2:10 p.m. I think all participants rejoined, except few. Yeah. Now I invite Professor Dr. Ghanshyam Chaudhary to deliver his lecture on management of moderate COVID in level 2. Welcome, Dr. Ghanshyam Chaudhary. Now you can share your screen.
Thank you, Dr. Rajkishore.
Yes, your slides are visible.
Okay,
but
thank you.
not in full screen mode.
Okay.
Dr. G.S. Chaudhary is from GMC Jalon. He is professor and head of Department of Pediatrics. And he will tell us about the management of moderate COVID in children in level 2. Now can start, sir. All participants rejoined.
Okay, thank you, Dr. Rajkishore. So, very good afternoon to one and all present here. First, I thank to DGME sir, Prajapati sir, Sally madam, Dr. Chandrakanta madam and her team for giving me opportunity to talk in front of so many faculty, residents and doctors of all over UP. So, topic given to me is management of moderate COVID in level 2. So after lunch, it is difficult to concentrate on lecture. So I will not take much time. So please bear with me. I will take about 20 minutes. So what are the learning goal of this lecture is? First, we decide what is the severity, level of severity of COVID in children. Many of the things we learned in previous lectures. So some of things are repetition and something new things are there. Management of moderate COVID, where we manage, whether we have to manage at home or in hospital. For mild cases, we manage at home. For severe cases, we manage in hospital. But for moderate case, what will we do? That we will discuss here. Monitoring is the key of success for any disease, any treatment. So how to monitor moderate COVID? When we investigate these moderate COVID cases, whether investigations are required or not, and if required, what investigation we should do, whether we should prescribe fluid, and in which form, either oral or IV, we will discuss here. And what are the different modes of giving oxygen therapy, because lungs are mostly involved in all COVID cases, most of the COVID cases, and they need oxygen. So how oxygen therapy is given, details are there after tomorrow, detailed lecture is there on oxygen therapy. So I will touch some parts of that. So diagnosis of COVID infection in children. So whenever we suspect COVID, like influenza-like illness, fever, rash, diarrhea, vomiting, abdominal pain, etc. So we do antigen test. And if it is positive, then it is confirmed COVID case. And if it is negative, then we go for RT-PCR test. And if RT-PCR coming positive, then it also confirms COVID. But if RT-PCR and antigen both are negative, then either it is no COVID, or if we have a strong suspicion or strong doubt of COVID, we go for repeat RT-PCR or CT chest after 48 hours. So if that is positive, then it is COVID. How we assess severity of the COVID in children? So we divide it in mild, moderate, severe, and critical. In mild cases, there is sore throat, rhinorrhea, cold, cough, loose motion, vomiting, but there is no fast breathing. So fast breathing is not there. Only symptoms are sore throat, rhinorrhea, cough, diarrhea, vomiting, abdominal pain, etc. In moderate COVID, along with these symptoms like sore throat, cough, cold, diarrhea, vomiting, there is fast breathing, and fast breathing in children is defined as age-based criteria. And in children less than 2 months, if respiratory rate is 60 or more, it is fast breathing. In children between 2 months to 12 months, if respiratory rate is 50 or more, it is fast breathing. In children between 1 year to 5 years, if respiratory rate is 40 or more, it is fast breathing. And children above 5 years, respiratory rate 30 or more is fast breathing, along with oxygen saturation between 90 to 94%. But there is no sign of severe pneumonia. So in moderate cases, there is tachypnea, fast breathing, age-based criteria. And there may be decreased SpO2 saturation between 90 to 94%, but no sign of severe pneumonia. Further classification is severe disease. There is severe pneumonia. Pneumonia is defined as like symptoms, sore throat, cough, cold, along with fast breathing, with any of these, like cyanosis, presence of cyanosis with pneumonia, oxygen saturation below 90%. In moderate cases, oxygen saturation is between 90 to 94%. In mild cases, no desaturation, oxygen saturation is above 94%. So here, cyanosis and oxygen saturation below 90%, increased respiratory efforts detected by presence of grunting or severe retractions. Severe chest retractions and grunting are signs of increased respiratory efforts. There may be lethargy, somnolence, seizures, unable to take feed, and vomits everything. If any one of these or combination of these present, then child is in severe disease. Next is critical disease. If presence of ARDS, acute respiratory distress syndrome, evidence of sepsis, septic shock, multi-organ dysfunction syndrome, acute thrombosis, MIS-C, multi-organ inflammatory syndrome in children. So if any one of these is present, it is critical disease. So how we manage moderate COVID? Ideally, all moderate COVID children should be admitted in hospitals, and there should be dedicated COVID care facility. Moderately ill children should be managed either in SDU or in PICU. And there is no specific management in case of moderately ill children. There is supportive treatment and oxygen therapy. These two things, supportive and oxygen, are the mainstay of the treatment. What are the supportive treatment? I will discuss later. And we should monitor. Monitoring is the key of success for management of COVID cases. And 4-hourly monitoring is required in moderate cases. And if case is deteriorating, we monitor more frequently. So we take in monitoring sensorium, conscious, unconscious. We monitor by ABPU scale, awake, on response to voice, response to pain, or unresponsive. We monitor pulse rate, pulse volume, respiratory rate, retractions, blood pressure, oxygen saturation, liver size, urine output. So these things should be monitored 4-hourly. investigations, we should do some investigation in moderate cases, and the primary investigations are complete blood count, liver function test, renal function test, CRP, X-ray chest, and blood culture if suspected bacterial infection. But if child is not improving or deteriorating, we go for other cases also, like coagulation profile. We go for PT, APTT, INR, D-dimer, ferritin, procalcitonin, CPK, ECG, and echocardiography. So in all cases, all investigations are not required. First, we do basic investigations, and if child is deteriorating, we go for further investigations. Fluid. Which fluid? Oral or IV fluid? So mostly we ensure adequate fluid intake and prefer oral fluid intake. If child is on breast milk, we advise to give breast milk or other milk or homemade fluid should be given. But if child is having diarrhea and dehydration, we should correct diarrhea and dehydration as WHO plans. So first we decide whether dehydration is present according to WHO criteria. We see general condition, eyes, thirst, and skin pinch. So according to that, we divide in 3 categories: no dehydration, some dehydration, and severe dehydration. If child is on no dehydration, we give homemade fluids and ORS. If child is having some dehydration, we manage according to plan B of WHO, we give ORS. If child is having severe dehydration, we manage according to plan C of WHO, we give IV fluids. If child is unable to take orally or poor intake, in those cases, we give IV fluid. Otherwise, we prefer to give oral fluids. What are the amount of fluid we give? So the amount of the fluid is little higher as compared to the adults. In infants, we give 150 ml per kg in 24 hours by infusion pumps or pediatric drip sets. So in adults, this much fluid we not give. And in younger children, we try to give by the infusion pumps. And we prescribe the fluid 6 hourly. Otherwise, 150 ml per kg they may give in 6 hours or 8 hours like that. So we divide this fluid in 6 hour or 8 hourly schedule. In children, we give for first 10 kg, 120 ml per kg per day. And for next 10 kg, we give 50 ml per kg per day. And for next 10 kg, we give 20 ml per kg per day. For example, if we have a child of 15 kg, so for 10 kg, we give 120 ml per kg, that comes 1200 ml. And for 5 kg, we calculate by 50 ml per kg, so it will come 250 ml. So for a 15 kg child, total maintenance fluid is required 1200 plus 250 ml, so 1450 ml in 24 hours. Similarly, we calculate for like 25 kg child. For 10 kg, 1200 ml. For 10 kg, next 10 kg, 500 ml. And for next 5 kg, 100 ml. 20 into 5 is 100 ml. So for 25 kg, 1200 plus 500 plus 100, it will come 1800 ml in 24 hours. Remember, this is maintenance fluid, but if there is concurrent losses, like child is having severe diarrhea, in those cases, additional fluid is also required. Then comes what is the type of fluid. So mostly we prefer N/2 saline with dextrose. It is available commercially, but sometimes it is not available. Then we can prepare it by using half volume of 10% dextrose and half volume of normal saline. So like we use, if we have to give 100 ml of the fluid, we take 50 ml of 10% dextrose and 50 ml of normal saline. then it will be prepared as N/2 saline with dextrose. We can give DNS, but we have to add potassium chloride if we have to give fluid more than 24 hours. And the quantity of potassium chloride is 1 ml in 100 ml of the fluid. Isolate P was also given previously, but it is not preferred nowadays. It is avoided because it is hypotonic. Other supportive treatment is antipyretic and antiemetic. In antipyretics, first choice is paracetamol. So paracetamol is best antipyretic and should be given 15 milligram per kg per dose, maximum 4 times a day. So paracetamol preparations are available in drop form, in syrup form, in DS form, double strength form. In drop, 1 ml contain most of the preparation of paracetamol drops. 1 ml contain 100 mg, and syrup 5 ml contains 120 ml. And double strength syrup contains 5 ml to 50 ml. Even 500 ml per 5 ml syrups are also available. So we calculate according to the preparation and according to the weight of the child, how much required. Second choice of antipyretic is ibuprofen, and dose is 10 milligram per kg per dose. And syrup contains 100 mg per 5 ml. So for giving this, weight is divided by 2, comes ml of ibugesic is required. Suppose if child is 10 kg, so 10 kg will be divided by 2, so it will come 5 ml. So 5 ml of ibugesic is required for 10 kg child per dose. Third choice is mefenamic acid. Dose is 10 to 25 milligram per kg per day divided in three divided doses. And fourth choice is combination of paracetamol and ibuprofen like drugs, or paracetamol and mefenamic acid. So these things are avoided. These are avoided. Mostly we use first paracetamol or this ibugesic. In antiemetic, we give domperidone. Domperidone is given by dose of 0.2 to 0.4 milligram per kg per dose. It is available in syrup form and drop form. In syrup, it is available 1 ml, 1 mg in 1 ml. In drop form, it is available 10 mg in 1 ml. And then second antiemetic is ondansetron. Dose is 0.1 mg per kg per dose. Usually it is given 3 times a day. And 5 ml of syrup contains 2 milligram of ondansetron. Then antibiotics. Antibiotics are not antiviral, and we know that COVID is a viral disease. So there is no role of antibiotics in COVID-19. But if there is a strong doubt, a strong suspicion of bacterial infection, or there is evidence by like procalcitonin level increased, we can give antibiotics. And the choice of antibiotic is first choice is amoxicillin. And dose of the amoxicillin is 30 to 40 milligram per kg per day in 3 divided doses. Second, we can upgrade to amoxicillin and clavulanic acid, or we can give injectable like ceftriaxone. So if there is a strong suspicion of bacterial infection, we can use amoxicillin, amoxiclav, or ceftriaxone. Then other supportive management comes is nebulization. An indication for nebulization is the presence of wheezing in child. But traditional nebulization should be avoided in case of COVID because there is aerosol generation. So preferably we should use MDI, meter dose inhalers with spacer. So this is meter dose inhaler. It contains canister, plastic holder, and cap. It fits in a spacer. Here is adapter. we fit here this portion of the inhaler, and we fit mask on this end. So preferably we use multi-dose inhaler with spacer, and it is used as preparations we use for this purpose is Asthalin meter-dose inhaler or Libolin meter-dose inhaler. These are bronchodilators and useful in wheezing children. If MDI is not available and we have used conventional nebulizer, we have to cover the face of the child with surgical mask to prevent aerosolization. For traditional nebulization, the available drugs are a saline respiratory solution, that is concentrated solution, and 1 ml of that contains 5 milligram of salbutamol. So for nebulization, we use 0.5 ml of this saline respiratory solution and 2.5 ml of normal saline. So we should make it 3 ml. If we contain only this 0.5 ml of this, the mist will not be generated in that nebulizer by the nebulizer. So we should make it 2.5 to 3 ml. So we take 0.5 ml of this saline respiratory solution and 2.5 ml of normal saline. So sufficient quantity of the fluid is present in the nebulizer nebulizer cap. So mist will be generated. It is also available in prepared form, ready-made form, respule form. It is available as Asthalin respule or Libolin respule. So we can use any one of these, and it is diluted form, so no need to add normal saline in these respules. Then coming to the oxygen therapy, tomorrow there will be a full lecture on this oxygen therapy. So I'm just touching some things of this oxygen therapy. So oxygen is required if there is decreased oxygen saturation below 94% and there is increasing distress in the child. Our target is to maintain oxygen saturation above 94%. We can also try awake proning in these children, and we change the position every 2 hourly. So mode of oxygen therapy is oxygen can be given by nasal prongs, by face mask, non-rebreathing mask, or if child is sick, then we can use high flow nasal cannula, heated humidified high flow, triple H, heated humidified high flow nasal cannula, or CPAP, or BiPAP, or negative pressure ventilators like mechanical ventilators, invasive ventilators. But these things are used in severe cases. In moderate cases, usually we use nasal prong, face mask, and non-rebreathing mask. In nasal prongs, there are three sizes of nasal prongs are available: neonatal, infant, and pediatrics. Depending on the age of the child, we use that size of the prong. And we give oxygen flow 0.5 to 4 liter per minute. We should not give more than 4 liter per minute by nasal prongs. It is very uncomfortable for the child if we give high quantity of this oxygen by these nasal prongs. And the FiO2 we give about 30%, 30 to 40% of the oxygen can be given by these nasal prongs. Second mode is by face mask. In this, we can use little higher oxygen, and different size neonatal, infant, pediatric size are available: 0, 1, 2, and 3 sizes. And the flow of the oxygen is 5 to 8 liter per minute. So by these face mask, oxygen flow can be given 5 liter to 8 liter per minute, and we can give oxygen 30 to 60% by this. So by this nasal prong, we can give only 30 to 40%, but by this face mask, we can give 30 to 60% of oxygen. Third is by non-rebreathing mask. In this, there is attachment of the reservoirs. So these are also neonatal, infant, and pediatric size are available, are small, medium, and large size. Oxygen flow can be given 9 liter to 15 liter. So little higher oxygen than the face mask is required by this. And FiO2 we can give by this is 40 to 90%. So if more FiO2 is required, more oxygen saturation concentration is required, we can give by non-rebreathing mask like this. So there are three modes in moderate cases for giving oxygen. One is by nasal prongs, we use 0.5 to 4 liter. By face mask, 5 to 8 liter. And by non-rebreathing mask, 9 to 15 liter. And oxygen concentration will increase by these masks. Then comes steroid, low molecular weight heparin, and remdesivir. So steroids are recommended only in severe and critical cases of COVID-19, and it will improve survival of severe cases. In moderate cases, it is usually not recommended. Anticoagulants are not recommended in any case for prophylaxis purpose. It is useful only in established thrombosis. Dose of anticoagulant like enoxaparin is 1 milligram per kg per day. It can be given by subcutaneous route and for 10 days, once daily for 10 days. Then comes antiviral remdesivir. It is usually not recommended in moderate cases, but can be given if child is hypoxic and if child comes before 7 to 8 days of onset of symptom. Most practical indication for remdesivir is rapidly progressive disease. So if child is having rapidly progressive disease and comes before 7 to 8 days of onset of symptom, we can use remdesivir. And dose of remdesivir in children above 40 kg is same like in adults, 200 milligram loading dose followed by 100 milligram once daily for next 4 days. So total 5 days. In children less than 40 kg, we give 5 milligram per kg loading dose on day 1, followed by 2.5 milligram per kg maintenance dose for next 2 to 5 days. Drugs like favipiravir, tocilizumab, hydroxychloroquine, chloroquine, ivermectin, azithromycin, lopinavir, ritonavir are not recommended for routine use in COVID-19 in children, and these drugs are not of any use for any severity of disease, and they are not used for prophylaxis also. What are the discharge criteria for moderate COVID? So we can discharge children after 10 days of symptom onset, and if there is clinical resolution of the symptom, and child should maintain oxygen saturation above 94-95% of the oxygen for at least 3 days. So if child is maintaining saturation above 95%, 95 or more of the oxygen for more than 3 days, then we can discharge after 10 days of onset of symptom. And we should advise at least 7 days home isolation and monitoring. These are the references of this module. What are the skills to be learned? We should recognize the danger sign. We should classify the severity of the pneumonia. And we should learn the skill of oxygen therapy. Thanks to all the contributors of this module. Thank you all of you for your patient listening. If there is any question, I'm ready to answer.
Dr. Ghanshyam Chaudhary ji, thanks a lot for such a nice presentation. There is no questions from participants. And now I am proceeding for the next lecture of today's session, which is the last lecture, interpreting chest X-ray. And this lecture will be delivered by Dr. Neeta Radhakrishnan from SSPS, PGTI, Noida. Welcome, ma'am. Welcome, ma'am. Dr. Nika, ma'am. Please share your slides.
Can you hear me?
Yeah, ma'am. Your slides are visible, ma'am, but not in full screen mode.
It must be visible now. Good afternoon, everyone. Before I start, I would like to thank DGME for this opportunity.
Ma'am, your voice is very feeble.
Just give me a minute.
मैम प्लीज माइक के पास से बोलिएगा. आपका प्रेजेंटेशन बहुत इंपॉर्टेंट है और कोविड के मैनेजमेंट का बैकबोन है ये.
एक सेकंड.
वेलकम मैम.
Is it clear?
Start now. Your screen is visible.
Is it clear?
Yeah, ma'am.
Is the audio clear now? Okay.
Yeah.
So in the next 15 to 20 minutes, we'll be discussing interpreting chest X-rays in pediatric COVID. And there are some slides in this presentation, some images which have been taken from literature, which have the sources of which have been cited. So what we will discuss in the next few minutes will be, one, how X-ray is different, how taking a chest X-ray or how interpreting a chest X-ray is different in this setting, that is pediatric COVID, compared to our normal routine X-rays, which we are ordering from our emergencies or from our OPDs. Second, while interpreting a pediatric chest X-ray, what all should be aware of? Like what is the normal outline of the mediastinum? What are the landmarks? That is slightly different from adults. So we will look at that. Third, what are the X-ray abnormalities of concern in COVID-19? Everything that's abnormal in an X-ray is not related to COVID-19. So we will see what is specific for COVID-19, what is not. And fourth, and probably the most important query is, when should we ask for imaging in COVID-19? So when should we ask for an X-ray? When should we ask for a CT scan? So this is the outline of the presentation. So for starting with the first question is, how is this X-ray different in this setting when compared to our routine X-rays? So in routine X-rays, when a patient is coming to us with a respiratory complaint or some say tachypnea, or when you are ordering a chest X-ray, we generally send the child to a radiology department or X-ray room for X-rays. When we are asking from emergency for very sick children, only then portable X-rays are advised. Otherwise, usually the patient goes to the radiology department. Whereas in pediatric COVID-19, in most cases, 95 to 99% of cases, patient would be actually admitted with a COVID report in COVID ward, and then you will be asking for an X-ray after that. So in almost all cases, it will be a portable X-ray. And because it's a portable X-ray, it's going to be an AP projection, and AP projections are a little different from your routine PA view X-rays, and that we should be aware of. It is a bedside X-ray. In many cases, the child would be having respiratory distress, would be on oxygen, or maybe if the child is more sick, the child might be even ventilated, in which case the X-ray would be a supine film also. It will not be an erect film. So we should be aware of these technical aspects before we interpret the X-ray. Now, pediatric interpretation again is slightly different. Pediatric chest is tubular in shape, one. Second, there are physiologically enlarged, like physiological changes in the X-ray. Like for example, a thymus which would be enlarged, which would be normal. Physiologically enlarged thymus would be normal till around 6 years of age. So that also we should be aware of it especially when physicians who have been dealing predominantly only with adult X-rays suddenly start looking at pediatric X-rays. We should be aware of what are the changes which are possible. Third, because of AP projection, because the heart is in the front, and when the AP projection is going from front to back, cardiac shadow can appear magnified, and because of which cardiac ratio or CT ratio is generally not calculated on an AP film, the heart can appear magnified. And also because the child is supine, then again on an expiratory film, all these three changes together, the heart magnification cannot be calculated on an AP film, and hence we will not rely on that. If we are feeling there is cardiomegaly, then we should be relying on other sources like an echo to evaluate further. And many a times children, when you compare with adults, children in respiratory distress or children otherwise who are irritable will not be, or children, very young children also, will not be able to hold their breath for X-ray. So expiratory films are very commonly seen, and in which case we should be aware that in expiratory films, the diaphragm will be pushed up and heart can appear larger. So these are the changes that we usually see. In addition to this, as pediatricians, we know when children cannot be kept still in front of the X-ray, especially sick children. So there will be mild rotation, which is expected. And when you evaluate these slight lucencies, radiolucencies, which come on one side when compared to the other, you should always be wary of this fact that it could be a rotated film. So that also has to be kept in mind. So this is how the X-ray is different in pediatric COVID setting when compared to our routine X-rays. Now, second is when we finally have an X-ray. And I think the one more important difference is that in a normal X-ray, I think the radiologist, most centers, the X-ray would go to the radiologist for reporting. Even if we are seeing the reports, film also, we will eventually send it to the radiologist for reporting. Whereas in pediatric COVID, usually the X-rays don't get sent. So we are only going to report these X-rays. So that is why it is important to know the basic surface anatomy and basically what is expected before we proceed further. So we have the X-ray, we have taken a child has come to our COVID ward and the X-ray was ordered, child is in respiratory distress and an X-ray is come to you for evaluation. So how will you see if the X-ray is good or not for evaluation? One, we'll see whether it is a PA or an AP film normally. Here in this case, we know it's a portable film, so it's an AP projection. So it's usually, so that part we already know. Second, we look at the penetration. If it is an over-penetrated film, the spine would be completely visible. Intervertebral disc spaces also will be very clearly visible. Whereas if it is just visible, that is the correct penetration that you want. And what happens if it is an under-penetrated film? The compared vertebral area, you won't be able to make out the bodies separately, one. And second, the lungs would look very dark, like lungs would look like emphysema in adults. So that kind of picture, highly translucent, that highly blackish color would be seen in the X-ray. So that would also tell you that it is an underexposed film or penetration is not good. So in an under-penetrated film, your lucencies may not be appreciated, one. And second, you may not even be able to see the vascularity, the pulmonary, the tracheobronchial as well as the pulmonary vasculature, the markings which come in the lungs, especially in the middle and the medial one-third, that won't be seen in the underpenetrated film. Third, you will look at whether it's an inspiratory or an expiratory film. In an expiratory film, like I told you, the diaphragm will be pushed up. The child is leaving the breath. That's the diaphragm will be pushed up. The heart will appear little, apparent cardiomegaly will be seen. Whereas in a proper inspiratory film, you can see up to 4 to 6 ribs, the posterior aspect of the ribs, around 6 to 7, actually 6 to 7 ribs will be seen in a proper inspiratory film. That is when you know that the lung area can be actually reported in this. In an expiratory film, you may not be able to see the lung parenchyma clearly. And finally, the fourth part, whether the X-ray is rotated or not. The rotation can be easily appreciated with the trachea and the clavicles. So the trachea should be midline. And second is the clavicles on both sides should be symmetrical to each other. So if your clavicles are symmetrical, but still the trachea is on one side, that means there is a shift in the mediastinum. That is an ominous thing. That means usually the trachea is getting compressed from one side or the other. Whereas if the trachea, if in an extremely rotated film, so that one clavicle is looking like this and the other is looking like this, that means the child has rotated while the film was taken, then you cannot use it for any interpretation, because most of the you need bilaterally symmetrical lung fields for interpreting an X-ray. So that is about whether the X-ray was good or not. So in portable, you can even ask for a repeat X-ray if you think it's an extremely bad film. When you send it to the radiologist, when you send it to a X-ray room, usually nowadays you have digital X-ray systems, so they can actually assess all this on the computer console only, and they can give you a good film. They can maybe take 2 or 3 also if the penetration is poor or the rotation has happened. So that is how you interpret an X-ray, the goodness of an X-ray. Now, third is what all will you look at it? So looking at the X-ray, again, if you follow a particular order in your mind, it's easy to keep that in mind for every X-ray. And second, you will not miss anything if you follow this pattern. So we start with the mediastinum. We start with the mediastinum, the left and the right borders of the mediastinum. We look at the pleural outline. We look at the hilum, the shadows in the hilum. Hilum means that area which is having the pulmonary arteries and the main tracheobronchial vessels. So tracheobronchial airways, which I had seen. So that is the hilum. You compare it on both sides. Fourth, you look at the main trachea and the bronchial translucencies for any evidence of shift or obstruction that can be looked into. Fifth, you look at the lung parenchyma, whether it is normally inflated, whether there is any lucency on both sides, whether there are any abnormal shadows on both sides. So that can be looked into. And finally, beyond the chest, you can always look at the chest wall. You can look at the ribs. You can look at the abdomen, because anyway, always in X-rays, there would be a little bit of upper abdomen that comes. So gas, ileum, air under the diaphragm, or funding gas bubble, all this can be seen. And even a Ryle's tube, you can see a tube in the funding gas shadow, and the rib outline for any asymmetry. This also can be looked into. So our knee-jerk response is to look at the lung parenchyma immediately. But if we follow this order, we are sure not to miss any abnormality in the X-ray. So we start off with the mediastinal outline. So the mediastinum, as you know, is the structure which is actually between the two lungs, and it is bordered. On the left side, you have the aortic knuckle. You have the left pulmonary arteries. Here I'm just tracing it out. Then you have the left atrium or the left atrial appendage, and then the left ventricle. So this comes the left side of the left border of the mediastinum. So depending on the prominence, you know what to expect there. Whereas on the right side, you have the vein, the main vein, which is the brachiocephalic vein continuing as the superior vena cava. So superior vena cava essentially. And after that, a little bit of right pulmonary arteries and veins. And then finally the right atrium. So here you must note that only the right atrium is part of the right border. The right ventricle does not come to as part of the right border of the mediastinum. And why is it important to know here again? If there is an enlargement here, it usually means right atrial enlargement and not right ventricle enlargement. And here is the area where you find the thymus normally, that is in the superior mediastinum. So any opacification here, you must think twice before calling it an opacity. It might be just a normal physiological thymus that comes here. And when we put a central line, because we're going to see central line position also later. So the central line is going to come here through the, wherever you're putting, whether you're putting it through the jugular or through the subclavian, the tip of the line has to rest between the superior vena cava and the right atrium. So this is the area where you're expecting the line tip to be. So if the line has come down here, you will pull it up a bit. So these are the borders of the mediastinum. Next, in any X-ray, we are usually after this step, you assess the cardiothoracic ratio. This is the formula for it, A plus B divided by C. And it is usually less than 0.5% or more than less than 0.55 in children. And in newborns, it will be 0.6. So anything more than 0.6 would be cardiomegaly in a newborn. But since I already told you that in COVID X-rays, it's usually an AP projection, we generally don't rely on this cardiothoracic ratio for looking at cardiomegaly. So in an AP film, as long as if the heart size is normal, it is normal. But if the heart size is appearing large, you cannot comment it as cardiomegaly. So then you need another way of evaluating it. Probably you go ahead and take an echo. Third is the mediastinal pathology. So if you have any abnormality here, say I'm finding some abnormality here, that can arise from the anterior, the middle, or the posterior mediastinum. And on an anterior projection, you cannot differentiate as it to the depth of the opacity. So for that, you can easily take a lateral X-ray if required, and you can call it anterior, middle, or posterior based on their location. If it is in front of the heart, it would be anterior. If it is along with the heart shadow, it is middle. And if it is behind, it would be posterior. And anything above, these are the compartments of the mediastinum, and anything above the sternal angle would be a superior mediastinum. So superior mediastinum usually has, superior and anterior mediastinum has the same contents. So it's usually a thymus. There would be some lymph nodes there. There would be some there can be a lower lobe of thyroid in some patients, especially in adults. So these are the usual contents. Middle mediastinum, you usually have lymph nodes, and posterior mediastinum, you have structures originating from the neurovascular area here. And usually we don't find like COVID-related abnormalities in this area. Now, so these are some pictures. You can see a patient with a mediastinal outline. You can see this is the RA and this is the SVC, which is continuing up. And here on the left side, this would be the aortic knuckle, followed by the left atrial appendage and followed by the left ventricle. Here on the right side, you can see there is an opacification now. Now, to an untrained eye, this can appear as an opacification in the right, say right upper and middle zones. You can be easily reported as a pneumonia, but you can see even from the X-ray, you know that this X-ray is of a small infant. So you're expecting a thymus here. So that can be, this can be because of this exactly that intensity, the opacification would be similar to that of a lobar pneumonia, but based on the location, and then you can say that this could be a thymus. So that is how you evaluate. Another picture is, this is a better picture of a thymus, and this is the classical sail sign that has been described in the thymus. You can see that it looks like a sail of a boat. So it has a peaking which is seen, which looks like a sail of a boat. So this is N. And although thymus is a midline organ, usually that enlarged physiological thymus is seen on the right side more than the left. And next, after the mediastinal shadow, now you come to the, what are the contents of the hilum? Now, hilum is this area which is just immediately outside. So I'll just go back to the surface anatomy. So this is the hilum, this area where you have the vessels and the tracheobronchial branches of the tracheobronchial tree. This would be the hilum. So here again, we have lymph nodes. So whatever is prominent here is usually either the vessel or the inflamed bronchus will be prominent here. So in a lot of respiratory infections, you find prominence in the hilum. And if there are lymph nodes like in tuberculosis or any other bacterial infection or viral infection, you can find prominence in the hilum. So this is the hilum. And again, in the hilum, you can see that the right side is usually little on the lower side when compared to the left. So that is also normal. And equal intensity will be there. The density of the hilar shadow will be equal on both sides. So one side, if it is more prominent, then it means that there could be a local inflammation at that point. So this kind of picture is usually okay. And it can be seen in a lot of viral infections where you just call it hilar prominence or peribronchial thickening, etc. So these are the images. Then you come to the trachea and the bronchi. So the trachea, like I said in the beginning, you have a trachea which is midline, and then it comes and divides into the bronchi. So you can see the carina here. So it should be, before you interpret trachea, you look at the rotation of the film, and then you look at the lung parenchyma and the chest wall. So this is the order in which we are going to follow. And if there is any obstruction, say if there is something obstructing here, the child may be coming with stridor. The obstruction can be from outside. The obstruction can be internally also. If the child is coming with a laryngotracheobronchitis, you can have thickening of the intima, because of which there is obstruction of the airway. So that also can be well made out in a chest X-ray. The trachea has to be just looked into. Now coming to the main part of the COVID-19 X-ray interpretation, which is the abnormality, which are the abnormalities of COVID-19 which are seen in the X-ray. So usually airspace abnormalities are what we are looking into, but before we are looking into the airspace, always exclude rotation. Whenever we interpret an X-ray, the airspace on the lungs, you usually should know where it is, because there should not be any inter-observer variation. So we usually call it, there are certain terminologies that we use. We call it lobar if it is bounded by a lobe of a lung. You have your fissures which are bordering it. So that is a lobar pneumonia. But usually in viral pneumonias and also especially in COVID-19 pneumonia, you will not get a lobar picture at all. You will generally see bilateral symmetrical involvement, which are called by some people as patchiness or streakiness or linear bands, etc. You also have to decide whether it is predominantly central or predominantly peripheral. Central if it's in the medial 1/3. So if it is if this is an X-ray, if it is the medial 1/3 of the lung film, lung parenchyma, then it is a central. Middle and peripheral gets reported as peripheral only. So central versus peripheral, that is again a differentiation that you have to do when you are reporting the X-ray. And finally, the zonal distribution. So in adults, we call it upper zone, mid zone, and lower zone, where in pediatrics, it's little difficult to, there's a small area to divide it into 3 zones. So generally they divide it based on the hilum position into anything above the hilum is upper zone and anything below the hilum is lower zone. So that is how it is reported. Now there is an international consensus on how we are to report COVID-19 X-rays. And even when you see X-rays, we should be able to understand what is typical of COVID-19 and what is not typical of COVID-19. So this is a consensus report which was published in 2020. And as based on this, they have classified findings in the lung as typical, indeterminate, atypical, and negative. So typical is when you 100% know this is very, very typical of COVID-19 and a very high chance that this will end up as COVID-19 pneumonia. Indeterminate is there are changes which are seen in COVID-19, and this could be seen in many other viral infections also. You're not very sure about it, but all the more, and this can be expected in COVID-19. Atypical is something which you don't expect in COVID-19. What are they? Like you find a unilateral lobar consolidation already said. A segmental consolidation. You don't see it in COVID-19 at all. You don't find single round pneumonias or air bronchogram like in bacterial pneumonias. You don't find it COVID-19. You don't find pleural effusion or even lymphadenopathy as a primary cause because of COVID-19. It may be due to another infection which is coexisting in the patient. And finally, if there are no findings at all, it is reported as negative. But then again, a negative X-ray does not rule out COVID-19 infection in the lungs. There are many times the X-ray pickup rate is not as high as CT. So many times X-ray findings may be, the lung imaging findings may be better described on a CT when compared to an X-ray. Now, what are the typical findings of X-ray? The typical finding is one, basically that is called GGO. GGO is ground glass opacities. So ground glass opacity was a radiological terminology which was used for CTs earlier. And nowadays it has been reported even in COVID-19 infection also. Where are these GGOs found? They are found bilateral. They are usually, it need not be symmetrical. It can be multifocal involvement, bilateral. And where is it located in the lung zones? It is located in the peripheral aspect. So peripheral or subpleural, bilateral, GGOs. These are classical findings in COVID-19. And GGO, after a while, what is GGO? GGO is like a little area of lucency, which is not very strong lucency, but as it progresses, it will evolve into a consolidation. So the density of the lesion will actually increase over time, and then it will resolve. So we'll see the progression also in a bit. So what if you don't have bilateral distribution? If you have unilateral GGOs, if you have central GGO, all that comes under the indeterminate and atypical group. So in indeterminate, you will have unilateral GGOs, or you can have peribronchial thickening bilaterally. So peribronchial thickening is again, which is thickening seen near the hilum. That is also seen in a lot of viral infections, including COVID-19. So it is called as indeterminate. It's not very specific of COVID-19. And you have multifocal GGOs. Then also it is called, without a particular distribution, if you have multifocal involvement, then also it is called as indeterminate. And atypical, I already said, anything which makes you wonder whether there is another cause involved, like a bacterial infection or tuberculosis. Many times, this presentation to the hospital for COVID-19 might just be a way to diagnose tuberculosis. The child might be having tuberculosis from before, and just because the patient came to us now, we end up diagnosing. So many times tuberculosis or pleural effusion due to some other cause, etc., can be picked up when the child presents to us for COVID infection. Now, this was one of the earliest papers which were described specific for pediatric COVID in 2020, which had 44 patients, and this was a center in Europe, where their admission criteria was at that time COVID with comorbidities they were admitting. So not all COVID was anyway admitted. So among this group of 44 patients, 50% had comorbidities like renal failure, renal transplant, or cancer patients, etc., were admitted into this. So this paper is one of the earliest papers which describe the classical features. So one of which is peribronchial thickening I told you about. So peribronchial thickening means it's just an inflamed bronchus, and that you are seeing as an end-on view. So the X-ray, you will have a bronchus going down like this. And if X-ray is taking, if you see the bronchus from end-on view, it looks like this. It looks like a lucency around which there is a cuff of thickening because of edema or inflammation. So that is peribronchial thickening. So this peribronchial thickening is obviously seen in the hilar area. in a lot of infections. It can be seen in CMV, it can be seen in COVID, adeno, RSV, common cold, common infections in the lung, viral infections, you can see this in changes, and it can be seen in even 80% of patients with COVID also. So in that classification consensus criteria, it is coming under indeterminate because it can be seen in many other viral infections also. The second finding that they described as GGO, so ground glass opacity. So ground glass opacity, to remember it, it looks like a frosted glass. So if you see frosted glass, if the frosting is little less, you can actually see what is on the other side. It's not very clear, but you still can see the other side. So it's similar to that. If you can see this X-ray here, there is an area of ground glass opacity. So this is a, sorry, this is a frosting-like appearance, but you can still see the lung, the vasculature through it, the lung markings through it. So that is how you differentiate from a consolidation. Whereas if you see here, it has become more dense. In B and C, you can see that haziness or that mild lucency has now increased and it becomes much more prominent. And here you can see the margin of the lesion. Whereas in this ground glass opacity, you won't be able to see the margin. So what is a ground glass opacity? A slight haziness which does not have any markings, lung markings, or which does not have any margins which we can clearly see. And through this haziness, you will be able to see the lung markings clearly. Whereas as it becomes more and more prominent or more and more consolidated, it looks more like a consolidation where you have a non-homogeneous opacity, where you have distinct markings which are seen, and you can see an air bronchogram also here. Very distinctly you can see the air bronchogram which is coming inside. So it is just the intensity of the lesion or the depth of the lesion that is important. And GGOs are classically described in many viral infections, but here it is seen in the periphery. It is usually seen bilaterally in COVID-19 infections. It's better seen on CT, but it can be seen on X-ray as well. So that is the typical finding we told already. You have multifocal or bilateral subpleural GGOs are very typical of COVID-19. So here again, you have bilateral picture. You can see there is GGO here. There is some GGO. There is some ground glass opacification seen here also. This is typical. Whereas this kind of consolidation pattern will be atypical. This kind of round pneumonia, which radiologists call this round pneumonia. So this is again a highly central lesion, highly consolidated, definitely markings are seen. That is again atypical of COVID, and this would indicate an additional bacterial involvement in this child. And here again, it would indicate bacterial infection. So these are all atypical on the right side, whereas a typical one would be on the left side. Here again, there are more pictures, the reference is given. Bilateral interstitial pattern here, bilateral interstitial pattern, and here the lower paracardiac interstitial pattern. So these are all, this interstitial pattern is exactly what we are describing in COVID-19 infection. Here again, COVID-19 focal consolidation on one side, which is usually atypical of COVID-19. And perihilar streakiness can be seen. That is a finding which is similar to your peribronchial thickening. That can be finding an indeterminate finding. So these are some X-rays from our patients. So again, X-ray does not indicate anything. You could have really bad X-ray and the patient could be doing well. So again, X-ray, although there are X-ray based severity scorings which are available like in CT, our ultimate discussion on treatment and how to escalate treatment would be based on the clinical scenario like tachypnea and saturation, etc., and not based on a chest X-ray at all. So here is a child, you can see both of them have severe respiratory difficulty. You have saturation of 85% in room air and 65% in room air. Both of these children, you can see X-rays, which could be classically, you have bilateral involvement, subpleural involvement, which is in, this is more consolidated. This is more like ground glass opacification. Whereas on the right, you can see again, typical X-ray, subpleural involvement mostly, and it is bilateral symmetrical involvement. So this is both severe COVID-19 pneumonia. Whereas the next two pictures, again, X-ray looks similar to our earlier two pictures, but you see the saturation, both of them have had a mild COVID infection, and these children were actually admitted for comorbidity. So one had a leukemia and another child had severe anemia. So these children were admitted for other reasons. X-ray, where COVID turned out to be positive, and X-ray is also bad. But X-ray, having a bad X-ray does not mean clinically they will be bad. They've never required oxygen, thankfully, in their hospital stay. So that is how, just to show you that severity does not really, X-ray severity does not correlate with clinical severity. And finally, severity scores are there, but then that's mostly for, I think, study purposes. For clinical purposes, we are not going to be using any of these scoring. And before we wind up the X-ray reporting, we do need to look at the tubes and lines. And many a times patients in the COVID ward, especially sick children, would have an endotracheal tube, or they would have a Riles tube, or they may have an ICD tube. So we need to know where these lines are. We're not going to be, many a time we don't generally take these X-rays for looking at the line, except in a central line. But when we take an X-ray for some other reason, we can definitely see whether the tube is properly placed or not. So you have an endotracheal tube positioned here. It is usually, you can see the carina here. There's a picture here. Yeah. So there is a carina. The carina is marked out here. So this would be around 4 to 6. The tip of the ET tube should be around 4 to 6 centimeters above the carina. That's your normal length. So the ET tube is coming down to the right side. Then you know it should be pulled up, that you can see. And this length of 4 to 6 centimeter varies. It could be in small babies, in newborn, it could be as small as 1 centimeter also. So depending on the age of the child, this is an appropriate distance that should be kept from the carina. And central venous line, I already marked out the surface anatomy earlier. So this tip it rests between the junction of the superior vena cava and the right atrium, which is coming here. So this position is appropriate. And if it is little down, you usually pull it out. But usually you mark it and do it. So generally that won't be a big issue. So here again, there is a peripherally inserted central line. So I'm not sure if you can see the lucency. I'm just tracing it with the mark. So it's coming like this, and it is ending here. So here it is perfectly positioned. You don't have to change it. Sometimes when children are, sometimes in children, because of short neck, it can go over to the opposite side. It can go to the jugular. Instead of coming like this, it can go up. So all these changes can be there. In a normal day, when you're doing it in an OT with a C-arm, you don't need X-rays. But in children where you're doing it in COVID ward, or if you're putting a central line in the ward, you will definitely need a chest X-ray to locate the position. Here again, Riles tube is properly, the tip is properly positioned here as well as here. Here the X-ray is a little rotated, so the course seems abnormal in this X-ray. Then the tip of the Riles tube again is around 7 to 10 centimeters distal to the gastroesophageal junction. You can make it out in the fundic gas bubble. And again, for Riles tube, you don't need an X-ray to locate the position. It is always clinical, but if you're taking an X-ray for some other reason, you can look at this as well. Here is a child who has an ICD tube. So you can also look at whether the ICD is placed positioned properly. And here again, many a times when you have an ICD tube, there would be surgical emphysema. You can see that air in the subcutaneous space can be seen, well demarked on the X-ray. And finally, X-ray is also done for complications. So what are the complications in COVID-19 pneumonia? One is worsening of the infection, where the child is worsening of severity. Child is not maintaining saturation at all, despite on all the ventilatory strategies that you have used. Second, if you're suspecting a secondary cause, like you're suspecting a pneumothorax, you're suspecting a pneumonia which has come up, you're suspecting a pleural effusion, etc., then again an X-ray can be taken. Third, if the child is ventilated, and by day 3, you generally take an X-ray, especially if there is increase in the respiratory settings, to look for a VAP or ventilator-associated pneumonia. And finally, fourth is when there are chances of pulmonary artery thrombosis. So this thromboembolism in the lung is very, very commonly seen in adults, whereas in pediatric age group, it's not so commonly done. So these are the 4 complications that you can expect in patients with COVID-19. So in ventilated patients, immediately if you take a chest X-ray, you can look at any wrong positioning of the ET tube, whether there is any collapse of one side or etc. After 3 days, you look at it for ventilator-associated events. And you can also look at lungs for pulmonary edema, pulmonary embolism, barotrauma. If you have been bagging a patient, there is a risk that there would be a pneumothorax. So that also can be looked at in the X-ray. So here you can see a pneumothorax on the left side. Here you can see that there are lung markings which are seen till the end here. You can see the small markings till the periphery. Whereas on the right side, it is not seen in the periphery. So there's very clear air shadow without any lung markings, with a margin, collapsed lung margin can be seen. So that is indicative of a pneumothorax. So that can be seen in that also can be seen in a chest X-ray. And So last question of this talk would be, when are we going to do imaging? Imaging, there are multiple recommendations. I think to do a chest X-ray in the COVID-19, the answer is very simple. In asymptomatic and mild COVID-19, you will not do an X-ray at all. In children who have tachypnea and children who have respiratory distress, children who have saturation which is low, so they come under the moderate and severe COVID, you will do a chest X-ray, one. Second, that is similar to any other pediatric patient who has respiratory distress and tachypnea. Second, you will do a chest X-ray if you're expecting any sudden worsening, like you want to rule out a pneumothorax, you want to see a collapse, or a ventilated patient not improving. So these kind of scenario also you will do a chest X-ray. No X-ray is taken as a screening strategy for COVID at all, and no X-ray is needed for asymptomatic or mild COVID, which would be our 95% of a pediatric population. And when do you ask for CT in a child? You don't really want a CT because of increased risk of radiation. You have to send the child to another center. You may need to do sedation. So these are all issues which come up for CT scan. But you are forced to do an X-ray or CT scan when you have a suspicion of a pulmonary thromboembolism. That is the only actual indication for a CT imaging in these patients, because thromboembolism cannot be picked up on an X-ray. So in that case, you need CT, you may need an echo, you may need other additional blood investigations also. And do we need to repeat an X-ray? However bad that X-ray looked like, you really do, if the child is clinically improving, no fever, tachypnea is coming down, saturation is good, you don't need to do a post-recovery X-ray at all. If there is a pneumothorax, obviously you will repeat it, but otherwise just pneumonia-like features in the lung, you don't need to repeat an X-ray at all. So this is my conclusion slide. When do you order an X-ray? Just to repeat, any moderate to severe respiratory illness, including COVID-19, you would order an X-ray. Whenever you suspect a complication, you would order an X-ray. What do you look for in the X-ray? We discussed the order in which how we are reading an X-ray. But for COVID per se, we look at the lung parenchyma, we look at typical, indeterminate, and atypical features of COVID-19. We look at complications like pneumothorax, collapse, etc. And we look at the lines and tubes, ET tube, central line, ICD, Riles tube, etc. And when do we really need to repeat a chest X-ray? No, there is no need unless you are suspecting any complication. I'll stop here and I'll be happy to take any questions.
Ma'am, there is a question for you. Dr. Sunil Kumar Sharma asked, please repeat criteria of cardiomegaly in X-ray.
So CT ratio is the A plus B. I can bring back that slide. The ratio is, this is how we calculate. This is on a normal PA view X-ray. So this is the maximum diameter on the left side, which is A. The max, you draw a line in the midline, and from the midline, the maximum cardiac shadow on the left side would be A. Sorry, on the right would be A, on the left would be B, and A plus B divided by C. So that is more than 0.55 in a child and more than 6 in a newborn would be a cardiomegaly.
There's only one question. Thanks a lot, ma'am, for such a wonderful presentation. And your presentation really is an eye-opener and is a foundation for the COVID management in pediatric age group. Without interpreting X-ray, it's not possible to manage a pediatric COVID patients. This one is our last lecture for today's session. Now you can conclude our today's session. Mamta people are there. Neeraj ji, you are here.
Yes, sir.
Yeah, so now we can leave.
Yes, sir. For tomorrow we have to join, sir.
Now you all can leave. All participants, all panelists can leave. And thanks a lot again for you all, for your active coordination, cooperation, and all panelists, all presenters presented very well. Our observers coordinated very well. Thanks a lot. You all can leave now. All participants